Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This is episode 2 of my review of orbital pathology for radiology board exams. At the conclusion of this episode, I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com, where you can also find other free downloadable study guides and other radiology content that may be of interest to you, so go ahead and check that out at theradiologyreview.com. For those of you who may be considering a Board Vitals subscription, remember that you can type in RAD Review at checkout, RADREVIEW, one word, RAD Review at checkout, to save 10% on most subscription plans. Also, if you want to check out MRI online, you can also use the same discount code RAD Review to also save 10% on many offerings with MRI online. I'll just take one moment to say Happy New Year in 2022, and for those of you taking the ABR core exam or other radiology board exams this year, now is really the time to solidify your study plan and start getting in the good habit of daily consistent study and preparation for your future test. Remember, you must prepare to succeed. Without further ado, let's get into the questions and answers for this episode. First question, what are common causes of raccoon eyes on physical exam in a child? If you do not know the classic appearance of raccoon eyes, which you can see by simply looking at a child's face, where you have periorbital hematomas, please check out images online because radiology board exams can simply present a picture, meaning a photograph, of an individual with raccoon eyes and expect that you know something about what that means in terms of underlying disease entities. Two leading differential considerations for raccoon eyes appearance on physical exam are metastatic neuroblastoma to the orbit as well as a basilar skull fracture. The clinical history should guide you towards one entity versus the other in terms of malignancy, such as metastatic neuroblastoma, or trauma to suggest a basilar skull fracture. Neuroblastoma is the top cause of orbital metastatic disease in children. These metastases often involve the bony orbital wall and frequently involve the lateral orbital wall and/or sphenoid bone, with periostitis that has been described as a hair-on-end appearance. Look as well for additional sites of metastatic disease if you are considering neuroblastoma, including extradural metastases. And remember that on a nuclear medicine scan, both MIBG and MDP bone scans can show sites of metastatic disease through different mechanisms. MIBG as a norepinephrine analog, and MDP through bone remodeling and calcium metabolism. Next, which subtype of breast cancer is more likely to metastasize to the orbit, invasive ductal carcinoma or invasive lobular carcinoma? The answer is invasive lobular carcinoma, which is more likely to metastasize to the orbit compared to invasive ductal carcinoma. There are certain key differences in the spread of malignancy between invasive ductal and invasive lobular carcinoma, and one key difference is the propensity of invasive lobular carcinoma to metastasize to the orbit. With invasive lobular carcinoma, orbital metastases may occur many years after initial invasive lobular carcinoma diagnosis and may manifest clinically with visual acuity changes or double vision and enophthalmos, which enophthalmos, ENOPHTHALMOS, is posterior displacement of the globe in relation to the bony structures of the orbit. Enophthalmos should make you consider metastatic invasive lobular carcinoma, whereas many other orbital tumors more commonly would cause something like proptosis. Next, what is the classic imaging appearance of optic neuritis? With optic neuritis, you would expect optic nerve enhancement and increased T2 signal within the optic nerve. Most of the time, optic neuritis is unilateral, and this can present with ocular pain. Next question, what is neuromyelitis optica? Neuromyelitis optica involves bilateral optic neuritis plus the addition of myelitis. So you have involvement of the optic nerves and the spinal cord. Clinical symptoms include ocular pain and vision loss and potential paralysis. Neuromyelitis optica is often a relapsing, remitting disease, which is similar to the clinical course of multiple sclerosis. Next, what is the classic triad of neuromyelitis optica? Neuromyelitis optica has been described as having a classic, although notably not exclusive, triad consisting of first optic neuritis, second myelitis, and third anti-aquaporin 4 antibody. Next question. What is the classic imaging appearance of thyroid orbitopathy? This is a particularly high-yield disease presentation to be aware of, and with thyroid abnormalities in the orbit, with Graves' disease, you would expect enlargement of the extraocular muscles, mostly involving the belly of the muscle, with sparing of the muscular tendinous insertions. The classic order of prevalence of extraocular enlargement is remembered with the mnemonic I am slow, I-M-S-L-O, I am slow. And I'm guessing for most of you, I'm not the first one to tell you this mnemonic because it's so widely known, but let's review it here. I, inferior rectus, M, medial rectus, S, superior rectus, L, lateral rectus, and O, oblique muscles. And that again is the classic order of prevalence of extraocular enlargement in order of most to least prevalent. So most prevalent is the inferior rectus, the I of I am slow. With thyroid orbitopathy, one can also expect to classically see an increased volume of intraorbital fat as well as exophthalmos. With thyroid orbitopathy, something like 10% of individuals will be euthyroid, so TSH testing may not necessarily identify the etiology of orbital findings. Thyroid orbitopathy is more common in females, and like many diseases that are more common in females, will have a more severe presentation in males. In the acute setting, you are more likely to see venous congestion, which can manifest as orbital fat stranding. In the chronic phase, you are more likely to have diplopia and restrictive myopathy. Next question. What are orbital findings associated with neurofibromatosis type 1? Speaking of high-yield entities for radiology board exams, neurofibromatosis type 1 is towards the top of the list. And with the orbit, neurofibromatosis type 1 can cause sphenoid dysplasia and buphthalmos, which is Buphthalmos, and buphthalmos presents as a smaller volume orbit. Optic gliomas and Lisch nodules of the iris may also be present. On a frontal radiograph of the skull, you should be aware that sphenoid dysplasia can produce the empty orbit sign, wherein the affected orbit looks, at least to my eye, smaller, as well as insufficient to accommodate an eye, therefore empty on radiography. And go ahead and look up images of the empty orbit of neurofibromatosis type 1 on a frontal skull radiograph if you have not yet seen that. Next, What are orbital findings associated with a cavernous carotid fistula? A cavernous carotid fistula creates back pressure to the orbits, which can cause pulsatile exophthalmos, proptosis, subconjunctival hemorrhage, and loss of visual acuity with cranial nerve 3, 4, V3, and 6 palsies. That is a lot. You may want to review that in writing by downloading the study guide at theradiologyreview.com. With a cavernous carotid fistula, you also would want to look for findings of orbital congestion. That includes retroorbital fat stranding, extraocular muscle enlargement, enlargement of the superior ophthalmic vein, an enlarged cavernous sinus, and possible findings of intracranial hemorrhage. A classic clinical history for a cavernous carotid fistula is trauma, followed weeks later by development of an erythematous, painful, and potentially teary eye. Carotid cavernous fistulas can also be more prevalent with diseases such as Ehlers-Danlos syndrome, and if an individual has something like Ehlers-Danlos syndrome, a cavernous carotid fistula can potentially occur spontaneously in absence of significant trauma. Confirmation of a cavernous carotid fistula is often done with angiography via an internal carotid contrast injection that shows the cavernous sinus together with the superior ophthalmic vein, thereby evidence of the cavernous carotid fistula. Thankfully, interventional radiologists can not only diagnose this entity, but they can also sometimes treat this entity with coiling, and often the patient may experience rapid or even immediate pain relief following coiling of the fistula by interventional radiology. If, on the other hand, treatment of a cavernous carotid fistula is delayed, even beyond something like 24 to 36 hours, according to what I've read, optic nerve infarction is possible and blindness can result. So prompt diagnosis and treatment can be key for the optimal outcome with a cavernous carotid fistula. Next question. What are some differences between retinal detachment and choroidal detachment? Retinal detachment often produces a V-shaped morphology in the orbit, as the retina has anchor points anterior and posterior centrally in the orbit and detaches between the anchor points. On the other hand, choroidal detachment has more of a U-shaped morphology if you bicep the globe and look at it from above, looking down. Or potentially with choroidal detachment, you may only see involvement of the lateral but not posterior aspects of the orbit, as the choroid does not attach at the optic disc. Choroidal detachment diverges at the optic disc, whereas retinal detachment converges at the optic disc. Next, what are top differential considerations for presence of leukochoria? Leukochoria is an abnormal whitish reflection from the retina, and you can sometimes see this on a photograph with a flash and lack of the red eye effect that is sometimes seen on photographs. The top cause is retinoblastoma, followed by persistent hyperplastic primary vitreous, which is due to a congenital anomaly with lack of regression of the fetal primary vitreous, and with persistent hyperplastic primary vitreous. Beyond leukochoria, you can also look for microphthalmos, a misshapen lens, possible retinal detachment, and so-called hyaloid canal that extends from the abnormal lens posteriorly to the orbit. Coats disease, COATS, can also cause leukochoria, which is also known as exudative retinitis, and with Coats disease, also termed exudative retinitis, leaking of lipoproteins causes retinal detachment. If you see leukochoria in a child on a board exam, I would think of retinoblastoma first, but I would also be aware that other considerations are persistent hyperplastic primary vitreous as well as Coats disease. Next, what is the top site of metastatic disease from uveal melanoma? The answer I am looking for is that uveal melanomas have a propensity to metastasize to the liver, which is the most common site of metastatic disease with uveal melanoma. Next, what is the mechanism whereby permanent diplopia can result from an orbital blowout fracture? The answer I'm looking for is that herniation of the inferior rectus muscle through the orbital floor fracture can cause entrapment and restrictive myopathy, thereby leading to permanent diplopia if not surgically fixed following an orbital blowout fracture. Therefore, look for and report presence of inferior rectus herniation in cases of orbital floor blowout fractures. On a similar note, an orbital apex fracture is in close proximity to the optic nerve, and if hemorrhage and hematoma occurs, this can potentially compress the optic nerve and potentially cause permanent blindness. Next, what is Tysis Bulby? That is Phthis, Tysis Bulby. Tysis Bulby is a shrunken globe, often related to decreased vitreous or aqueous humor. Causes of Tysis Bulby include trauma, which can cause loss of vitreous or aqueous humor, or inflammation or other causes of aqueous or vitreous humor production loss. Next, what are classic imaging findings for an optic nerve sheath meningioma? Perhaps most classic for an optic nerve sheath meningioma is a tram track enhancement pattern of the optic nerve, which is common and results from enhancing tumor surrounding the non-enhancing optic nerve, as well as possible calcifications and possible hyperostosis of the adjacent bone. Clinically, an optic nerve sheath meningioma can present with proptosis and visual loss. If you are presented with bilateral optic nerve sheath meningiomas, you should immediately consider Neurofibromatosis Type 2. Remember that the optic nerve has a blood-brain barrier and will only typically enhance if it is diseased in some way, such as with optic neuritis. The normal optic nerve is typically non-enhancing, and if you have an optic nerve sheath meningioma, you would see the tram track appearance from the peripheral enhancement with central non-enhancing optic nerve. Remember again that bilateral optic nerve gliomas should make you consider neurofibromatosis type 1. On the other hand, bilateral optic nerve meningiomas should make you consider neurofibromatosis type 2. So bilateral optic nerve gliomas, NF1, bilateral optic nerve meningiomas, NF2. Next, true or false? The majority of cases of orbital lymphoma will also have systemic lymphoma. The answer here is true. About 75% of orbital lymphoma patients will also have systemic lymphoma. Orbital lymphoma, like other orbital masses, can present with proptosis and diplopia. Next, what are classic features of an orbital fibrous histiocytoma? An orbital fibrous histiocytoma is a circumscribed enhancing orbital mesenchymal tumor that is most commonly benign and most commonly presents in middle-aged adults. A classic history could be an individual with prior treated retinoblastoma or some other type of orbital tumor that was treated with radiation who now presents with an orbital mass that is a post-radiation induced fibrous histiocytoma. If you are given a history of prior radiation, then the fibrous histiocytoma is more likely to be malignant compared to fibrous histiocytomas that arise outside of the setting of prior radiation therapy to the orbit. Next, what entity should you first consider in a child or young adult who develops exophthalmos when they get a viral infection? The answer I am looking for is an orbital lymphangioma, which is due to lymphoid tissue hypertrophy reacting to a viral illness. An orbital lymphangioma can also present with proptosis following only mild orbital trauma. This entity can hemorrhage and cause fluid levels on MRI. Differential considerations for an orbital lymphangioma include an orbital rhabdomyosarcoma. And that leads us to the next question. True or false? Orbital rhabdomyosarcomas are typically painless. The answer is true. Orbital rhabdomyosarcomas are almost all found in children and teenagers and are more common in males, and these present clinically with a rapidly enlarging, painless mass with proptosis and visual changes. The 5-year survival for an orbital rhabdomyosarcoma is over 90% with appropriate chemotherapy and radiation therapy. Let's conclude this episode with a few rapid-fire bonus tips. First, the ophthalmic artery enters the orbit through the optic nerve canal with the optic nerve, and the ophthalmic vein exits the orbit through the superior orbital fissure. This orbital anatomy is somewhat tricky and important for board exams. The superior orbital fissure and optic nerve canal are separated by the clinoid process, and the superior orbital fissure is more lateral than the optic nerve canal. Next, remember the posterior chamber of the eye is the space around the lens that is actually anterior to the vitreous humor. Next, retinopathy of prematurity and congenital toxoplasmosis can both result in a small calcified orbital globe. Next, bilateral lacrimal gland enlargement can be classically seen with lymphoma, sarcoidosis, and Sjogren's disease. At least those are the main entities I would consider for radiology board exams. Next, if you see bilateral lacrimal gland uptake on a nuclear medicine scan and are asked to name that scan, I would think of a gallium scan first, and I would also consider whether this is a technetium 99M pertechnetate scan, meaning a free tech scan. Final bonus tip, orbital lymphomas classically show restricted diffusion, whereas orbital pseudotumors classically do not show restricted diffusion. Last and final question for this episode. Why is the orbit called the orbit if it doesn't orbit anything? The answer is that nobody knows. That concludes this episode. I hope this was helpful for you. There is a lot of dense information that I have presented, and it may be helpful to listen to this episode again, as well as download the study guide that you can get for free on my website, theradiologyreview.com. If you have suggestions for topics for future podcast episodes, feel free to contact me at theradiologyreview@gmail.com or on Twitter or Instagram @RadRevPodcast. Also, don't forget to follow me on Twitter or Instagram, or both, @RadRevPodcast, where I post on a near daily basis some sort of knowledge tip for radiology board exams or simply radiology education. Thank you for listening to this episode. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.